Hello and welcome to Exploring Strategies for Managing Costs Associated with SDOH Interventions. This work group session is part of the Texas MCO SDOH Learning Collaborative with support of the Episcopal Health Foundation, the Texas Association of Health Plans, the Texas Association of Community Health Plans, and the Health and Human Services Commission. Just a couple notes for today. This session is being recorded. We structured it as a work group session, so most of you will be muted upon entry, but you can unmute yourself and contribute to the chat. We have a lot of people on the call today. So to ask a question, you can click the raise hand feature located at the bottom of the participants window, and then we can then call on you and then unmute your line to ask your question. As we get a feel for the group and the amount of people that willing to chime in on the discussion, we might loosen this rule a bit, but for now, the raise hand feature would be much appreciated. Feel free to keep your camera off when you are not presenting, but do please turn it on during the group discussion. So my name is Diana Crumley. I'm a senior program officer at the Center for Healthcare Strategies. In my past life, I was a Texas resident. I also worked for the Texas Health and Human Services Commission. So Texas has a very special place in my heart, and I'm very excited to be with you here today. I'm also joined by Xiaoqi Sim, the Vice President for Applied Research at the Episcopal Health Foundation, Jennifer Carreau, the Senior Policy Advisor at the Health and Human Services Commission, Justin Burrell, the Principal and Consulting Actuary at Milliman, and Jeff Milton-Hall, the Consulting Actuary at Milliman. So for today's session, we'll review how SDOH-related activities are being classified and reported, with a specific emphasis on activities that improve healthcare quality. This is often called QI, especially in Texas. And then we'll identify what additional guidance would be helpful for plans to support additional SDOH-related interventions. We came to this topic because we heard interests from MCOs. And so a lot of this agenda is structured to relay what we heard from you with regards to activities that improve healthcare quality and potential barriers to supporting SDOH interventions. So we'll have some opening remarks from the Episcopal Health Foundation. Xiaoqi will also provide an overview of some relevant MCO survey results. I'll give a little bit of a national landscape of practices across the country as it relates to activities that improve healthcare quality and additional SDOH-related services. Then we'll have the HHSC team provide an overview of its MCO survey results, as well as of the overall efforts to provide potential QI guidance. And then we'll also have two actuaries from Milliman summarize what they heard from you in some informal interviews that occurred earlier on this month. Then we're going to have a group discussion. And so that's when we really want to hear from you. You can type in the chat if you're an introvert, if you're an extrovert, you can contribute to the discussion. And then we'll do a quick wrap up and kind of gauge interest for any follow-up sessions on this topic. And with that, I'm going to turn it to Xiaoqi Sim from the Episcopal Health Foundation for a few opening remarks.
Great, thank you so much, Diana. And welcome everyone. On behalf of the Episcopal Health Foundation, the Texas Association of Health Plans and Texas Association of Community Health Plans, my two thought partners, Kay Garamari and Lori Van Hoos, We wanted to extend this warm welcome to all of you to this very important learning sessions on managing costs associated with SDOH interventions. And what you're going to be hearing from later on is that our colleagues at Center for Healthcare Strategies have planned a very exciting and important agenda. So to sort of kick off the conversation and provide some context to our sessions, let me just spend a couple of minutes to share with you, and many of you, and thank you again to many of you who have completed the MCO SDOH survey late last year. In terms of some of its major findings, and I have both Kay and Laurie here in case any questions or comments that you guys may want to make. Next slide, please. So just a couple of important questions that we asked at the survey, right? First was questions about, what are some important factors that influence your plan's SDOH investment or strategies? I think there's no major surprise here. We were hearing loud and clear that community needs data, quality considerations, and mission and values of the organizations are really important, for plans decision making in terms of investing in SDOH strategies. Next slide. We had also asked in the survey, what were some top priorities for the SDOH investment from plan perspective? Not to our surprise, food insecurity, which is really, an issue, kind of like, first and foremost in many plans attention, followed by utility assistance, and housing needs. Although we could see that interpersonal safety and employment, are not that far behind. And next slide, which is my last slide. This is also an important question that we had asked plans about in terms of what seems to be, some of the government actions or policy issues, that would help them, incent them, to do more in the SDOH space. Again, issues like, rate adjustment to avoid, to protect plans from premium slide, adding social services as covered benefits under the state Medicaid plan, and so on and so forth. And definitely one of the key priorities that plans have identified, is really hopefully, that we all could work together on integrating efforts to address social issues into quality improvement activities, which is a kind of great segue into today's important topics. So before I end it, just wanted to see if Kay and Laurie have anything to add. If not, we'll turn it back to Diana.
Thanks, Sean. Oh, go ahead, Kay.
I was just going to say good afternoon to everybody. It's really great to see we have a number of the health plans that are participating, and we have spent a lot of time with Episcopal Health Foundation and Center for Healthcare Strategies. Really appreciate everything that they've done to work with us over the last couple of years and bring to fruition the two surveys that we've done. This we kind of see as one of the most important topics, which is how do we make sure that you get credit financially for what you're doing, and even more importantly, to build sustainability for your efforts. So appreciate everything that Xiao-Qi and everybody from CHCS are doing. And we'll certainly want to hear your questions and concerns, because that will give us some of the things that we need to be looking at in the future to help out our health plans.
Yeah, I'll just echo what Kay said. Thank you everyone for joining us. I'm so glad to see a large participant group. We've been meeting with Episcopal Health Foundation and Center for Healthcare Strategies for a while, and we've been telling them that this we feel is one of the biggest conversation pieces that you guys have been anticipating and wanting to have. So I'm really glad to see the turnout kind of is proving that. And we really encourage you, like we said today, to be a dialogue. So the extent you guys can chime in and provide some more input and insight into what will help you, I think will go a long way. And thank you to everyone that was able to complete the survey, and everyone else for all your work you're doing. Looking forward to it.
All right, well, thank you so much. So as I noted, I'm here to give you a little bit of a national landscape. And for those of you who don't know the Center for Healthcare Strategies, we do work in almost every state in the nation and pride ourselves on having our finger on the pulse as it relates to social determinants of health and Medicaid managed care specifically. You may have heard the old adage, if you've seen one state Medicaid program, you've seen one state Medicaid program. However, federal law provides a pretty good baseline, and as a lawyer, I definitely can start there. The short story is that with Medicaid managed care comes more flexibility. Yes, under federal law, rates must be based on state Medicaid benefits, and those things are defined in the state plan and waiver services to the extent that waiver services are carved into Medicaid managed care. However, MCOs can provide any service, including services that address health-related social needs. And MCOs have significant flexibility to target and tailor approaches for different patient populations to improve healthcare quality. You may have seen a recent letter from the Centers for Medicare and Medicaid Services that's devoted to the subject of addressing social determinants of health with Medicaid and CHIP. It's a fairly lengthy document, but for those of you who are interested in Medicaid managed care, specifically that section is about 2 or 3 pages. And summarizes some of the things that I'll be talking about today. So if you are a plan in any given state and you are considering an SDOH related program or intervention, you might have 2 sets of questions. The first set of questions would be math questions, the numbers. And then the second set of questions might be policy and program related. So when going and considering with an SDOH related intervention, you might wonder if the cost can be reported in the numerator of the medical loss ratio. And as I noted earlier, we have a specific emphasis today on activities that improve healthcare quality. That's a specific category of the MLR numerator. The answer to this is usually yes, because it's fairly easy with SDOH to make a connection to healthcare quality. But the second question is a little bit more complicated. Can the cost be used to develop rates? As I noted, rates must be based on state plan services and waiver services. So this is a trickier question. The answer is sometimes no. There are some exceptions within lieu of services, but it's just something that paints the picture of what an MCO's motivations might be. And then the third question might be more indirect incentives oriented. An MCO might ask, will the initiative help me earn incentive payments based on quality performance? Many states have some kind of quality program. In Texas, it's called P4Q, which I always thought was a cute name. Will the initiative help the MCO earn an auto assignment preference? Often those have a quality component as well. And the next category is fairly an emerging topic. Will the initiative help the MCO earn changes to the profit margin, efficiency adjustments? So the second set of questions might be program and policy oriented. Within the last 5 years, a lot of states have expressed interest in social determinants of health and have integrated requirements and incentives in their Medicaid managed care contracts about the subject. And where would these be hiding? Usually it's in the context of care coordination. For example, the plan must screen for health-related social needs, provide referrals, track the outcomes of those referrals, partner with community-based organizations, hire community health workers that can aid in those care coordination strategies. You might also see things in the quality assessment and performance improvement section. Many states have begun to require SDOH-related performance improvement projects. You might see requirements around value-based payment, essentially requiring MCOs to think about ways that they can partner with network providers in value-based payment arrangements to fund MCO interventions. You might also see a new topic, emerging practice, community reinvestment requirements, essentially requiring the MCO to invest a certain percentage of its profits into local communities and health-related resources. You might also step back and consider a state's policy priorities. And most states will state their policy priorities in their quality strategy and other sort of formative roadmaps and documents. And you might see an interest in improving health outcomes, in addressing disparities, and supporting network providers and enabling innovation. So I have a couple of state examples for you. Of course, no place is like Texas, but there are some states that have thought in detail about activities that improve healthcare quality and incentivizing MCOs. Oregon is one of those states. It has something that they like to call health-related services. And those health-related services must meet the federal definition of QI. Some examples are food prescriptions, legal assistance for those about to experience eviction. The costs are reported in the MLR numerator for those health-related services. They are not used to develop rates, but there is a number of documents online that suggest that there's a non-benefit load adjustment associated with health-related services. MCOs can also earn quality incentive payments. They have a fairly active incentive program there. Often this is indirect, unrelated to the health-related services, but of course, investment in social determinants of health often has an impact on health outcomes and healthcare quality. And there's also something that they're doing called a performance-based reward. And that's essentially if the MCO meets cost and quality targets and spends its money on health-related services, then the MCOs or the CCOs in Oregon can earn a wider profit margin. So the shorthand for this is often variable profit margin. It's very wonky, but it's one way to incentivize MCOs to provide more additional services or health-related services that are not covered benefits. Another example is New York. New York is also a DSRIP state, just like Texas. And just like Texas, they were required to come up with a VBP roadmap. And in that VBP roadmap, there's a description of advanced value-based payment arrangements. They use levels there, so level 2 and level 3. And the requirements for those advanced value-based payment arrangements is one SDOH intervention being integrated and one partnership with a community-based organization. Now, that roadmap essentially says that the MCO must provide seed money or a funding advance for that SDOH intervention that's integrated into value-based payment arrangements. And those particular MCO expenses that are within the VBP contract are reported in the MLR numerator and also used to develop rates. And again, there's indirect incentives for this work. MCOs can earn quality incentive payments and also an auto assignment preference. And finally, we have an emerging state practice, as I noted earlier, called community reinvestment. And that's essentially when states require a certain amount of profits to be invested in local communities. For Arizona, it's 6%. For Ohio, this is an upcoming requirement for its next phase of managed care, it's 3% of its annual profits, and that's increases to up to 5%. North Carolina and its new Medicaid managed care program also allows plans to contribute to health-related resources in lieu of a MLR-related rebate. They also will allow investments that are consistent with the state's quality strategy to count in the numerator of the medical loss ratio. So this just gives you a little bit of a picture of what's happening in other states, and hopefully will inform some of our discussion today as we move to the Texas specific portion of our agenda. And with that, I'll turn it to the Health and Human Services Commission.
Hello, my name is Jennifer Carreau, and I'm on the district team at HHSC. Today, I'll be sharing with you the results from the survey we conducted last year about quality improvement cost reporting. That survey was part of the work we're conducting as the part of the district transition, and one of our milestones in the transition plan is to issue clarifying guidance to MCOs about quality improvement costs. So we surveyed MCOs to find out what your questions were. As this session is part of the SDOH Learning Collaborative, I'll be focusing my remarks on how this relates to SDOH strategies. Sustaining the successes from district is one of HHSC and CMS's goals with the district transition, and services to address SDOH are one of the priority focus areas. Next slide, please. In Texas, quality improvement costs, or QI costs, are the label that we have for activities that improve healthcare quality as described by 45 CFR 158-150 and 158-151. They're reported on the financial statistical reports separately from administrative costs. They count in the numerator of the medical loss ratio, and which can help MCOs meet minimum MLR requirements. They may be included in the rate development process, and they do not count towards the administrative cap when calculating the experience rebate. QI cost claiming can support flexibility for MCOs to implement certain interventions to address social determinants of health for Medicaid clients. Next slide, please. As noted, this survey was done to better understand MCO's questions and current reporting practices. And we got an 85% response rate, so thank you very much for that. We designed the survey to start around the categories of the QI costs in the federal rules and then ask some open-ended questions. And after we go through the results of the survey, we'll have an opportunity for some feedback and questions. Next slide, please. As you can see on slide 4, most of the MCOs felt that the reporting template permits MCOs to report all of their allowable QI costs. A few had questions about what is allowable, and 2 others did not think they were able to report all of their allowable costs, either because the template did not allow it or because the reporting process was too complex. Next slide, please. In a separate question, just over half of the MCOs stated that some additional guidance would be helpful, and we are working on that guidance right now. It is due by the end of June at the latest. Obviously, we're trying to get that done as we can, and unfortunately, today we'll not be able to answer questions about preliminary guidance or anything like that, but we will be able to answer more general questions. Next slide, please. This slide shows the categories of allowable QI costs included in the federal rules, and we'll go into detail on each of these categories in subsequent slides. Next slide, please. The first category is about improving health outcomes and reducing health disparities. And I bolded sections that I thought were most related to SDOH, but this text is directly from the federal rules. So this category includes costs for case management, care coordination, chronic disease management, among other things. Next slide, please. 13 of 17 MCOs said they're already reporting everything they believe would fit into this category for QI costs. Next slide. Of the 4 who are not, some things they mentioned that they did not report as QI costs, but thought could be allowable were costs related to HEDIS administration, vendor activities that they currently put in medical spending, and current health IT costs, or certain health IT costs, excuse me. Next slide, please. The second category is about preventing hospital readmissions, which includes discharge planning, patient-centered counseling, et cetera, to help ease care transitions. Next slide. All but 1 MCO said they were already reporting all allowable QI costs. The one that did not give a detailed response of what else they might want to report. Next category. Next slide, please. The third category is about improving patient safety. Next slide, please. 2 MCOs were not sure that they had reported all allowable QI costs for this category, and 1 indicated that they had reported prospective prescription drug utilization review elsewhere. Next slide, please. The fourth category is for services to implement, promote, and increase wellness and health activities. And this can include wellness assessments and coaching, patient counseling, and other educational activities to change member behavior or conditions. Next slide, please. For this category, 5 MCOs indicated that they were not sure they had reported all services that would apply as QI costs. Next slide. The majority that indicated they were unsure cited uncertainty about what value-added services, if any, could be reported as QI costs. Next slide, please. And the last category is about activities to enhance the use of healthcare data, which includes advancing communication with patients and providers and supporting the management and transfer of data. Next slide, please. The 2 MCOs who indicated they might have other services they could claim as QI costs did not provide additional relevant details here. Next slide. So after going through the categories, we then asked broader questions about what services MCOs provide but do not claim as QI costs because of uncertainty regarding that cost claiming. And 11 MCOs said there were no additional services that they thought they could claim. 4 said that they provide services or referrals to address SDOH, some of which are currently value-added services. 1 said they might consider indirect quality costs such as analytics, and 1 said there were many costs but did not specify what those costs were. Next slide, please. And another question, 9 MCOs said there were no additional services they would provide if they were deemed allowable expenses, while 6 mentioned services to address SDOH or expand what they currently offer as value-added services. Next slide, please. Most MCOs indicated that they do contract out at least some of their QI costs to Medicaid providers. However, the examples that were given, it was unclear whether those were with Medicaid providers or just other third parties. Next slide, please. Most, but not all, MCOs indicated that they do evaluate whether their QI services are cost effective. Next slide, please. And lastly, 15 of 17 MCOs who responded say they do evaluate whether each type of QI service is increasing quality, though they do so in different ways. And this concludes my presentation, and I'm happy to take questions or wait for the later discussion section.
Are there any questions? And feel free to use the chat as well if we have a shy group.
I do see that Lori Van Hoos included a question. I'm not sure if that was for me or for you, Diana.
Yeah, Jennifer, I was just asking Diana if she'd had a chance to look at TennCare. I really haven't had a chance to dig into it or anything, but I know the new big waiver that was approved for Tennessee had some SDOH components in it.
Yeah, so I haven't looked at the approved version in detail, but certainly one of the general principles behind some of the flexibility that TennCare sought was to have some flexibility with regards to health-related social services, social determinants of health. So that's one way to kind of sell the general flexibility with that administrative cap. Do we have any plans that are active in 10 Care that perhaps have colleagues there?
Hi, Diane, this is Kay. One of the things I was thinking was, you know, there may be things that the plans are contemplating or maybe already paying for certain kinds of services that they don't even realize could potentially be available for claiming under the QI. I'm just thinking of just a few of the kinds of services that some of the health plans are doing, and almost think, you know, Jennifer, if you and your team at HHSC would be willing, you know, for us to do some test cases on some scenarios that health plans, you know, might want to invest in. You know, I think they're claiming the cost they think they can claim, but they may not know kind of the realm and the boundaries on which they can claim additional things that they're probably already investing in or may contemplate investing in.
Yeah, so I definitely couldn't answer that today, kind of a yes, no answer today, but we would definitely like to hear those situations so that we can kind of use that as we are developing our guidance and try to address that in the final guidance when it is issued. So absolutely, you know, that's kind of what we were hoping to do through that survey. And we did get some specific examples, some specific questions, but I think more granularity would be great. So plans can submit that through you, or you know, we can collect some of those questions today and take them back and use them as we are developing our guidance.
Okay, great. And I think I can work with Lori Van Hoos with THP and maybe reach out to a few of the health plans that we know are doing some things that are really innovative that might be pushing boundaries, just to see if they might be claimable costs, because we would like to, you know, make sure they are able to claim as much as possible. And it's a new world, so we'll work on that.
Okay.
Thank you.
Mm-hmm.
And Karen Love, I see a question perhaps for me. It says, I missed the third component. Are you referring to activities that improve healthcare quality? What's the third component? Yes, please, she says. Jennifer, do you want to go over that just real quickly?
I think, are you referring to kind of the general requirements in the federal rules? I'm sorry, I can't see the chat from this person.
The
So we
third
didn't.
component is improve patient
Oh, okay.
safety,
Is that
perhaps?
what they're talking about?
Mhm.
I did move quickly through that one. I think if you go back one more slide, you'll see the text. So those are the examples in the federal rules. I didn't focus on this one because it is perhaps less directly related to SDOH. But again, these are just the examples listed in the federal rules. So identifying best practices, encouraging evidence-based medicine, things to lower risk of hospital or facility-acquired infections, prospective prescription drug utilization review, and also importantly, you know, the health IT components and quality reporting necessary to do these activities. So those are part of this as well. I'm not sure if that answers the question.
And I neglected to say, but we'll have these slides available publicly afterwards. And so no need to take detailed notes. We'll have the slides available.
Yeah, and these examples are copied and pasted from the federal rules, so they are publicly available as well.
Any other questions? In this virtual environment, I'm comfortable with silence, so we can sit here for just a little bit as people ponder. Otherwise, we can move on. All right. Well, I hope you're thinking about some questions and some comments and reflecting on some of your experiences with activities that improve healthcare quality and cost reporting on the FSR. Next, I'm very excited to have two actuaries at Milliman present. Some of you may have had conversations with them earlier on. So again, this is another opportunity for us to summarize what we heard from you and then move on to really hearing directly from you, your questions, your concerns, continuing barriers, things that we can do to better improve the health of Texas Medicaid members. So with that, I'll turn it over to the Milliman team.
Hey, thank you, Diana. This is Jeff Milton-Hall. We can go to the next slide with our pictures on it. So I'm a consulting actuary with Milliman, primarily work on the plan side, supporting MCOs with their financial reporting, cost management, competitive procurement bids across Medicaid, physical, behavioral, dental health, and also supporting plans with their ACA rate filings. And I really just have to say thank you to CHCS and the Episcopal Health Foundation for sponsoring today's session and inviting Milliman to join. And I'm joined by my colleague, Justin Burrell, if you want to introduce yourself.
Thanks, Jeff. Again, my name is Justin Burrell, and I've worked for most of the last 25 years in Medicaid and on the state side of things. So from that perspective, including Hawaii, Idaho, Nevada, Washington, Utah are where I've spent most of my time, and seeing some of the challenges, you know, even from a state side who wants to do some of these things. Well, which things should we be doing, and how do we pay for it, or how do we address it, and those kinds of things. So so I'll add a few of those comments as Jeff walks through some of these slides, but open to, you know, comments as well. Our hope is to get through some of the slides quickly and move into more of a discussion mode. So.
Okay. So we were asked to join today's collaborative, and we're really happy to be here. And so ahead of it, to kind of really make sure that we had the relevant context, we sent out an informal survey through the Texas Association of Health Plans and Association of Community Health Plans to a few of the member plans to just get some of their thoughts on the SDOH interventions and quality improvement activity reporting, and some of the considerations for doing this specifically in Texas. We can skip this first slide since I think everyone has the definition, the background on SDOH, and talk about some of the meat here. So this first slide just introduces at a high level some of the key challenges that I'm sure you're all familiar with for both states and plans trying to address SDOH through Medicaid and Medicaid managed care, including the financing, finding the funds to support and incentivize SDOH interventions, sustainability, which is a big challenge where, you know, if the interventions end up reducing medical costs or improved health outcomes, that can ratchet down the experience base and cause capitation rates to decline over time, which can make it challenging to sustain and support these interventions over a long period. The third bullet we've highlighted in red because that's really key to today's discussion. This has to do with how to categorize SDOH interventions for the purpose of financial reporting, and then the treatment of these cost categories with respect to medical loss ratio rules, experience rebates, gain sharing calculations. And so that'll be a key topic since we're talking about quality improvement reporting. Other considerations include timelines for ROI, which can be challenging if it takes years for savings to materialize, tailoring quality measures for incentive programs, whether it's provider incentives or plan incentives, collecting quality and comprehensive data and ensuring that that is transparent and well communicated. And then just the authorities, the regulatory authorities for how Medicaid works to ensure that these services can be covered and ideally, if possible, included in the capitation rate. Next slide, please. So again, the key topic for today's collaborative is the subject of quality improvement activities for SDOH. And so in 2016, with the release of the Medicaid Final Rule, or the Mega Reg, a medical loss ratio requirement for reporting was introduced in Medicaid, and quality improvement activities are a key part of this, as Diana mentioned. So quality improvement activities are basically a category of non-benefit activities and expenditures that meet certain criteria established in federal regulation related to improving health outcomes and quality. And so I believe it was Jennifer earlier walked through several of these considerations, but as she mentioned, they must be designed for one of several purposes, whether it's improving outcomes, health outcomes, preventing hospital readmissions, improving safety. They must also satisfy several criteria, including improving healthcare quality, objectively measurable with verifiable results, benefiting the plan enrollee specifically, and basically generally accepted by recognized professional bodies, so evidence-based or quality organizations recognizing them. Also, certain activities that might otherwise qualify are categorically excluded, such as developing provider networks or certain types of utilization review. And so the reason that quality improvement activities really matter in kind of the modern Medicaid managed care is that they're treated as a benefit expense. So in the numerator, for example, of the medical loss ratio formula, rather than as an administrative expense. And so for Texas, with the financial statistical report and its experience rebates program, this allows more expenses to count towards the benefit expense and not as profit, therefore allowing plans to retain a larger proportion of their underwriting margin if they're in a gain position. And then for SDOH purposes, this is also important because some, though not necessarily all, social determinant of health interventions might qualify as quality improvement activities. Next slide. And so we spoke to several of the Texas health plans and really thought through what are some of the key challenges for addressing SDOH through QIA, because it's not always totally straightforward. The first challenge just simply being that not all activities to address social determinants of health necessarily comply with the federal definition of QIA, which is referred to in the Texas FSR instructions. Importantly, for example, that the interventions must solely benefit the enrollee population, or if they benefit others, it must be at no additional cost. They must demonstratively improve health outcomes and be evidence-based with verifiable results. Furthermore, a big challenge, and several plans mention this, is the requirement to document and itemize and account for QI or QIA expenses. And so even if a plan is performing these interventions, they'll need to separate out the compliant QIA activities from other activities that might be performed by the same staff or in the same activities. And so that can be a challenge. And of course, it's only really financially meaningful, again, if a plan would be in a gain sharing position. Another key challenge that plans have faced and can sometimes mention is ambiguity or uncertainty regarding what activities can be categorized and whether they will be accepted, for example, during an audit. A number of plans mention not so much uncertainty, but that they would prefer more guidance, for example, or explicit cost categories. And so I know the HHSC representative spoke to this, that there might be guidance forthcoming, but certainly several plans mentioned that it would be helpful to have more clarity on what activities are encouraged for classifying as QI. And finally, related just to really all SDOH interventions, is the concern of sustainability due to premium slide. In particular, if these interventions are effective at reducing healthcare costs, but are not included in capitation rates, it can be challenging to sustain them over a long period of time. Next slide. And so our last slide here just really covers some key considerations for both state actuaries and health plans with respect to social determinant of health interventions and quality improvement reporting. So Justin's going to go first with just covering some of the key considerations from a state perspective.
Yeah, I think one of the goals, obviously, of many of the states is just overall health of the population. And, you know, in some of our states, that includes Medicaid and public employees, almost putting them in the same bucket of what can we do across the board. So very general, very high level, but what can we do to make things better? And we have this Medicaid program as a vehicle for part of that, at least. Another challenge is, you know, short-term versus long-term interventions and costs. There are some, I think, expenses related to social determinants of health that have an immediate impact, you know, that reduce inpatient days, those types of things. And so it seems very much worth it. And now how do we finance it? How do we pay for it? An example might be, I know in one state where the health plan was basically paying for an apartment and had several rooms there. And there were some members who had high behavioral health needs. They were homeless and they were in the inpatient setting and could not be released to be homeless again, but they could be released to a home. And so they were funding this, but now how does that get paid for? All that we see as actuaries is that the inpatient days went down. And so, you know, that's a significant cost and an immediate savings, but now what? Some of the other things, you know, you might have, you know, you're providing various benefits, meals, other sort of things that may have an effect long term, but maybe don't, and you don't really know. And so that's some of the challenges. Another challenge has been mentioned here, and we refer back to some of the guidance from CMS is what can I do and you know, under the waiver, under the state plan, what happens with value added services? What if it's part of a value-based contract, or what can be included in that? All of those types of things come into play, and you know, what can be included. I've known of some fairly creative plans. I know one plan that you know, some of the MAT services for addictions, those members weren't coming in to get those services, so they bought an RV and took it to those members. Now, how did they pay for it? They plastered their health plan name all over it and called it advertising. And so, you know, what does that look like when you're doing rate setting, or you're looking at their financials and so forth? So those are the kind of challenges. And I think communication is key, and being able to be transparent. In that situation I just mentioned, all we see is maybe a lot of expenses for advertising. You know, is that needed? Is that too much? You know, is this admin too high? One of the things that I found, and it kind of relates to actual soundness too, is that sometimes you'll see a health plan with what we might characterize as high administrative costs, because a lot of interventions and such might be flowing through as admin, which is where QI generally is, you know, in the rate setting side of things too. But if that's flowing through into that, and so now we see this high admin, do we want to penalize a plan with high admin if their net costs are also much lower? Effectively, those are good investments with their admin. At the same time, do we want to pay everyone more admin who aren't doing all the same things? So that's the challenge as the actuary, where you have, you know, 3 or 4 or 5 plans, or in Texas, probably, I don't know how many plans, where they're all very different and what they're doing is very different. And so how do you deal with that? And then, you know, actual soundness. The American Academy of Actuaries, kind of one of our governing bodies, has recommended to CMS that we have more formal way to track investments and to include those in the capitation rates. Nothing necessarily is out there now, but that's the type of thing that I think is going on, where I think that over time, I think the best situation is where we know where the investment is best. What's the bang for the buck, and then what's the best way to track that and to properly pay for it. It is a situation, and I've heard from plans where I think that they feel like, why should I do a ton of this if it just reduces my rate, and then I have, I can't continue staying that rate because the money that I was used to invest to get that to that point is now gone. And so I think finding a way that mutually works for the state and the plans to where we do bring those overall costs down over time, but we do it in a way that we're transparent and people kind of know where that money's going.
Yeah, thanks. And from a plan perspective, I think there are some similar considerations too. I mean, first of all, just like with the state, the considerations aren't all just about dollars and cents. I think the plans also, many plans have in their mission a goal of supporting their members, health outcomes and well-being, and the same for the communities in which they're active, the outcomes there. Beyond that, plans have the consideration challenge of determining and operationalizing effective interventions for SDOH, whether that's through QIA or other mechanisms. So, QIA isn't always necessarily the appropriate avenue or the best avenue to address SDOH. So we've talked to health plans, for example, that are using provider incentives through value-based payment and alternative payment models to get the providers to tackle that. And sometimes that can help because those costs can sometimes be included in encounters and be part of the capitation rate. But for when using QIA to address SDOH, the challenge also comes up of categorizing and accounting for these costs and ensuring that the plan has a robust kind of documentation and cost itemization process to really track these costs and get them to pass an audit. And then there's the key consideration too of making sure that these interventions are sustainable in the long run, because the plan really wants to see them through to completion. And, if they're going to make these investments and efforts, they really want to be able to continue them and ensure that it's not going to be something that will not be sustainable over a period of time. And so that is our slide. So with that, we're certainly open to questions for us and our perspective, or we're happy to hand it back to Diana to facilitate the open discussion.
Any questions?
One of the I did mean to mention too, while I was talking about determining interventions, is the CMS state health official letter that came out recently is also one good place to look in terms of it lists a lot of interventions that CMS believes would be appropriate under Medicaid authorities for states and plans to pursue. So it's got at least a fairly good list of approved ways to address SDOH. Okay.
Jeff and Justin, I had a quick question. So it sounded like earlier you said that there are states that are provide a little more guidance, and then some that are a little more broad. I mean, what are the pros and cons of having kind of more specific guidance on what can qualify for QI?
I think that the guidance, in my mind, I think if the state comes out and says, look, these are things that that can be done, and even maybe more so, and things that we would like you to be doing, I think then that really helps them feel like that they can just, show their cards. Yes, here's what we're doing. Here's the cost. Here's how we've been categorizing it. I think in the situation I described, I think some plans were almost afraid to say anything to the state about what they were actually doing behind the scenes, for whatever reason. And I think from my perspective as the actuary, I think it's better to know, well, oh, I see where those costs are. Those are valid, useful costs. Your admin isn't high. It's, I can explain it. One of the challenges, I think, and if anyone from HHSC, I'm sure would echo this, is that we do get a lot of pushback, whether it be from CMS or from legislators and those types that say, why are we paying 15% admin when, you know, I think our fee-for-service program is at 3%. And so that's the challenge, is those are two totally different things. The stuff included in this admin, the QI, all these other things, it's different. And so to the degree that we can explain that, it's much better.
If they get too prescriptive though, is there also, does it impact those plans that may be doing stuff that don't fall within whatever the state decides to prioritize or categorize? So would you then limit any health plan's ability to, you know, continue exploring other options?
You know, I think that at least the states that I think I've been working in, that there has been more of a, you know, we want to see what you're doing. There's some times where they're saying, look, we're going to focus on homelessness, and so let's address that. Or, you know, there are some sort of things that are being pushed. But I think there's other things where, you know, we'd love to see what you're doing. We actually have to report to people about, you know, what are you doing related to all these things? And we don't even know what you're doing. And so if we knew this, the better. I think if a plan were spending an enormous amount of money for limited benefit, you know, that might be something that they would want to talk about and say, you know, maybe you shouldn't be doing that, or maybe we're not paying for that in the rates. But I think the more that they know, the more that they actually feel justified in the investment.
Thanks.
Yeah, and I'd say too, like, you know, I think the risk of guidance is that it could be overly prescriptive or limiting, you know, given that, you know, the federal regulations are fairly broad in terms of what they accept. But the general consensus we got from the plans we spoke with seemed to be a desire for a little more kind of guidance and encouragement of what activities are encouraged and instructions and categories for splitting it out. So I think plans might feel, you know, either more safer, or just feel like they have clarity on what is really appreciated in terms of activities, if there is some degree of guidance. So I think if you can try not to be overly limiting to plans kind of creativity for solving these issues, but at the same time providing a sense of what is encouraged and providing some categories for breaking it out. I know several plans said they'd love to have some SDOH related categories, for example, in the FSR.
I would add too that, I mean, maybe each health plan, maybe it's confidential or whatever, but I think having each health plan not having to reinvent the wheel on every type of intervention, I think is great. You know, if there was a little bit more of a collaboration there, even to the point of shared investment. You know, sometimes if each health plan invests in the same thing, you know, now you're double, tripling, et cetera, the cost of that. Whereas if they kind of go in on it together, you know, those are other opportunities. And so that I think is helpful as well. Is the more that's out there, what's working, what's not working, you kind of get all those best practices together.
Hey, Jeff, this is Anna Spencer from the Center for Healthcare Strategies. Do you have any examples of plan collaboration, sort of on what those interventions or social determinant needs might be?
So just in terms of just general, what types of interventions would qualify as QIA in terms of, I mean?
No, just if you've seen other plans collaborating on addressing, just to the point you just made, if there are examples you can share on sort of what specific activities plans might be collaborating on, so that they're not sort of duplicating their efforts.
Justin, I think this one's for you if you've got it.
I think one of the areas that I've seen a bit of is in relation to coding and homelessness in particular, is that I think that the plans all collaborated with all the providers. They're usually all the same providers, and we want to track certain of these things better. And so, you know, we're going to encourage our providers to code in this way. And then through that, and then I think also a shared, I would say, investment or resources, and that they were getting together and saying, you know, what are the community benefits for homelessness, or tracking of who's homeless, and how can we all, you know, access that or invest in that. And because one of the things that we found, and this is a situation in Hawaii where nobody could really know, you know, who are the homeless people. And so, well, we have all these different resources. How do we access them? How do we share with them what we're seeing, and all of that kind of thing? And so I think that's one area. Ultimately, that actually led to us, and I mentioned, I think at a TAHP speaking session a month or so ago, we've actually incorporated that into risk adjustment as well. And so once we've identified, we have a system for sort of monitoring and addressing those that are homeless. We also found those homeless had much higher costs, not just related to, you know, some of these social investments, but also just medical costs. And so we adjusted our risk adjustment related to that. So I think that's one example.
And I saw a question in the chat from artist Khalsa, if I'm pronouncing that right, around examples of value-based payment approaches for SDOH. And, you know, I know at least one way to kind of get there is sometimes through adjacent measures. So rather than paying directly for a specific SDOH intervention, you can have, you know, quality measures that might be related to, you know, access to care or other SDOH type needs, or you can have a total cost of care kind of risk sharing model, where if the provider is at risk of, you know, inpatient costs for their members, then the provider might be incentivized to address, you know, housing needs or other issues that would affect readmission risk, for example. And so you can get providers to really share in both the risk and savings of quality and member health outcomes that can address it. And I'm sure there are more specifically tailored examples I'm not thinking of.
I think the total cost of care ones are the ones that I've seen, to where those providers are tracking, you know, their various surveys when they come in to understand the social needs of the individual, and then they are reimbursed based off of total cost of care savings. And so that to the extent that it makes sense to make some of those investments, they can just do it. And then those costs kind of get bundled up in a payment to the providers that are allowable within the cap.
Yeah. And I guess also just kind of whole person care models where you incentivize providers to really, you know, not just provide, you know, the individual services when the members come in, but to track and manage their healthcare throughout the whole system and their interactions with other, you know, providers, specialists, facilities, and the like.
Yeah, I'd be curious to know from the plan's perspective, if they feel that, you know, the flexibility and the value-based purchasing or alternative payment models that you're working on gives you guys the ability to reward providers for the SDOH, or, you know, addressing some of those quality metrics that hit state SDOH. I don't think we've talked about it quite in depth to understand to what level that's maybe happening in Texas, and if we feel that that is a good model to use to address it, just because of the reporting that then also is required from all the alternative payment models that you guys are investing in.
And I think this, just to add on to what you're saying, I think, Lori, that is really important. You know, there's those Z codes that are part of the ICD-10 that allow for providers to be able to bill for being able to document certain, social determinants issues that their patients may be experiencing. And, companies can then look at that data, provide incentives and that kind of thing. So it doesn't necessarily all have to be through the QI component, but there are ways that I think, particularly because providers are really dealing with the patient firsthand, that we need to make the best use of that strategy as well.
Yeah, and this is Joe with Driscoll. I agree with that, Kay, and that's something I think that we need to investigate more and have done some at this point, though we haven't implemented anything yet. But those Z codes would allow your PCPs especially, and maybe your specialists to give feedback to the plan from their interviews with the member, about what some of their needs are that may inform us and our community health workers and our wraparound programs with social workers and resource coordinators, that, we can tailor some kind of programs to individual members or groups of members to meet some of those needs. I think that's a great way to enhance the incentives we may be able to provide to our physicians.
Along those, and I mentioned it before, but the use of the homelessness Z codes. One of the things that we found is a little bit of a critique that say, well, that's not really useful, because if we see that this person is homeless and it's coded, let's say in 2020 that they're homeless, but then those diagnosis data aren't really going to be used until 2021 or 2022. Is it of any value that this person was homeless back then? And so we did a bunch of modeling of, well, what happens here, and then what's their costs here, and adjusting those risk factors. And what we found is it was still material. That I think a lot of those people that are being coded, they have chronic needs, chronic situations, especially those with behavioral health needs as well. And so knowing who they are, even if it feels like it's temporary, there probably is real opportunities there to address needs down the road.
And I think a big challenge just for that coding is making sure that it's getting coded comprehensively and consistently too. I think that can be a big issue with SDOH. It's just making sure that the data on it is high quality, current, and comprehensive. And so I think that's something that, as Justin mentioned, can be a real collaboration between states, plans, and providers to get on board with kind of some coding recommendations for capturing that information, because it's certainly helpful not to fly blind. And then that also lets you potentially measure some outcomes if you see shifts in that coding over time.
Question, Justin, on the history related to that risk adjustment, was it just something that the state, like the agency, made a priority and then decided to work with the plans and develop a risk adjustment around? Was it legislative directed, or how did you guys get there with that idea?
To be honest, it started with, for me, with Medicaid expansion, and we had in the state of Washington a general assistance unemployable group that was state funded only, and there was one health plan that served all of them. A lot of drug users, mental health needs. There's a lot of real significant issues there. A very expensive population there, and they were a subset that then ultimately got rolled into our Medicaid expansion. And so they weren't a large part of it, but the way that the expansion worked is that if you had a relationship with a prior health plan, then you automatically were assigned to that health plan. And so, people who'd been in and out of Medicaid, you'd kind of connect them. But what it did is it took this entire population and moved them in. And so we tested out our regular risk adjustment models and found them just to be totally inadequate. They weren't really capturing the cost of these members. That was $1,200 PMPM for a $300 PMPM type overall population. So we looked at all kinds of things to try and get there. And ultimately, the thing that really we found to really help was that they were predominantly homeless. And so as we factored that in, then that made it, obviously not a perfect model, but a much better model. And so at the same time we were doing that and found that to be a real good predictor, then in Hawaii, they were also doing some, trying to get into their waiver, some of the tenancy support, housing support benefit. And it seemed natural to then incorporate that risk adjustment there as well. So kind of by accident, I guess, we stumbled on it.
Hi, this is Jimmy Blanton with HHSC, and thank you for the presentation. It was really excellent. And I have a question about the way we set rates in our, for medical costs. We use a community rating system, which basically is allows the market to kind of put some control on medical spending based on competition. Is there any way that something like that could be incorporated into a strategy on how to sort of, put some, or how to target the correct amount of investment for social determinants?
I think that's a great question. And I think a lot of the states that we are in it's basically, that's kind of the model, right? You set kind of a community average type of a rate, and then each health plan is basically trying to better than the average in order for them to, have some profits and be sustainable. The challenge, I think, and this is, some of the discussion, is what of that plan that in order to get to that level of savings has to invest more on some of these other types of things. Where does that come into play, or even does it? I think in some cases with a plan that their net overall PMPM is lower than others, but their admin, because of some of these kind of things, makes it higher than others. They can kind of get double penalized, I would say, in that we're not going to give them the full admin that they're spending. And in the way that some of the MLR, or in the states I work, their gain share or their corridor calculations, they kind of get penalized again for that higher admin. So one of the ways that this is helped is, well, if you can count some of those as QI, then now it becomes a medical expense, and you go from there. I think that's one of the challenges, though, is that in this model of, hey, you go do your thing, health plan, and if you're better at it than others, or then better at it than the rate that we've set, then good for you. What if, in order to be better at it, or to be significantly better at it, they're doing some unique things here? I think you'd want to create a model such that you encourage those unique things to the extent that it is ultimately savings, better health, those kinds of ththings. I think the challenge is, and this is from my perspective, is you don't also want to just throw money at something and say, here's another 3%, 4% in the rate, go do social determinants of health. And then, what if somebody doesn't do any? Now they just added that, money for nothing. Or they're just not good at it. They're not investing in the right places. So that's I think the real challenge is, I think most people feel like there's some benefit here, but where is the investment? And then how do you pay for it? And there's a bunch of different models as to how it can be paid for. Not all of them are paid for prospectively, like in the capitation rate. Some of them are paid for, in a settlement or something like that, but which isn't as ideal, I think, from the health plan's perspective, but it does at least give some incentive. I don't know if that helps or not.
And to add to this too, I think QI is certainly one way to incentivize it, though that's really primarily valuable if plans would otherwise be in a gain share position. But there's also, incentives can be used to vary, results by plan or revenue by plan in certain ways, or otherwise incentivize enrollment or things for plans that meet certain SDOH adjacent quality measures or outcomes. And then, states have also, I think Washington, just if I'm right, has encouraged plans to engage in a certain level of alternative payment models and value-based payment with providers. And so, if a state encourages, certain benchmarks for that, that can get, plans and providers on board with doing it. And the nice thing there is, since those models are benefit costs in the cap, plans are reimbursed for their care provided through these models. But there's obviously lots of different ways you can kind of go about incentivizing it, and they all have trade-offs and drawbacks.
Yeah, I've also seen through the withhold and/or incentive payments. So you can have an incentive payment of up to 5% of the total cap rate, where you're, effectively after the fact, paying a plan who did some things that you wanted them to do, or achieved something, or whatever it might be. Now that's an add-on payment. So I'm not aware of many states that do that, but that's one way that you would actually get the money to the plan that did X, Y, or Z versus just spreading it among everyone. Another one that I've seen more of is the withhold. You might put some money into the cap rate, but I'm not going to pay it for, you're not going to be doing these things, or you're not going to be getting the outcomes that we want. Then there's no money. And so effectively is the withhold, and then those get the money back who achieve those things. Challenges with all of those models, but those are some of the levers that I've seen states using. And as Jeff mentioned, the value-based, in Washington, one of the withhold measures is the percentage of their total spend that is in a value-based or alternative type arrangement. Not all of those necessarily include social determinants of health, but it does try to move away from just a standard fee-for-service model. And I think there was from Karen, there was is any state incentivizing the use of Z codes by provider? I mentioned just at least through risk adjustment, I think it's being encouraged. I'm also, because, if you don't see those codes, then you're not necessarily getting credit for that. I've also seen health plans take the risk adjustment model that the state uses to pay the plans, varied amounts. And then they, in turn, took that same model and faced it towards their providers and said, look, we're going to pay you based off the same model we're getting, thereby encouraging use of those codes by the providers as well.
And just a note there, Pennsylvania also requires its patient-centered medical homes to report on Z codes, and that's essentially passed on to the MCOs as a requirement. So that's another example of a state requiring reporting of Z codes. There's also screening requirements that are integrated into Medicaid Accountable Care Organization requirements. So examples of that are in Rhode Island and Massachusetts.
Joe has a question on the CDPS and the risk scores there. The CDPS base model doesn't necessarily take into account those Z codes. We have done an add-on basically to that model. And so we've taken, and effectively what we've done is we've said, okay, look, if we apply all of the other conditions that somebody has based off of the CDPS model that would say, they have asthma or they have behavioral health coding or whatever it might be, that would get us to this rate. But based off of in this case, homelessness or chronic homelessness, we see that doesn't get us close. There's another gap there. And so we would add, we have an add-on code for that. And I think, and so then it just gets added on as if it were another condition, like asthma or cancer or something else. And so it goes to their total rate. I believe that Minnesota does a similar sort of thing, although I don't think they're using CDPS, but for a population-based, more of a care coordination type of a payment that goes out. So it's not necessarily risk adjusting the entire cap, but this other payment. So they're doing that as well. So those are a couple of models.
And just remind me, is it Massachusetts that has the community stress-based model where it's based on like the census zone or something like that, and it's not specific to the members, but instead to the zip code or geography?
Yeah. So Massachusetts does, and so homelessness, education, crime, all these kinds of things come into play. It's not necessarily on the members, but where the member lives. So if the member is in a community that is experiencing a lot of these challenges, I think the idea is to, one, help maybe incentivize a plan to invest in that area as a geographic area in addition to the member. But they have that. We looked at some of that in Hawaii, and there's just challenges. You need to have enough base of information there, I think, to make it useful. I know that in our talks with Massachusetts, in some ways, they didn't feel like the R squared was really improved that much with some of those types of metrics, but that what it did do is it still added focus and made people think about it more, because they were going to pay you more if you were in those areas, even if crime in whatever area the member lives in wasn't necessarily a great medical predictor. It was their way of still encouraging investment.
Right. I think though that encourages potentially investment and aligns revenue for plans with cost. It doesn't necessarily encourage the improved coding, since that data wouldn't be based on Z codes, for example. So it's
that portion of the of their model would be lacking. But.
So we're coming up on time, and I want to give plans the opportunity, however uncomfortable it may be, to reflect on their current reporting practices, perhaps be able to communicate directly with the HHSC employees on the line in terms of what they would like to see in terms of more guidance, a question that they always wanted answered. Feel free to put that in the chat box or to unmute your line. But given that we only have about 5 minutes, I really want to make sure that we walk away with some actionable takeaways for the HHSC team. Don't be shy, y'all.
Is there, if we don't have any of the plans that are wanting to speak up, another thing that potentially we could do, Diana, is Kay and I could, follow up the plans following this and kind of get their reaction and their thoughts. They may be still absorbing all of this and trying to figure out where we go from this. And I think a lot of times they kind of want to talk internally about where they want to go or what their ask may be. So, I definitely encourage anyone to speak up, but also offer to take that back as well if we don't get any good feedback right now.
Hi, Lori. This is Dr. Srao from Driscoll.
Dr. Srao?
So I think from HHSC, I think it would be probably nice from the plan standpoint if we kind of create maybe some kind of incentive for the plans or something where we kind of develop our own kind of initiatives or projects that looks at SDOH, so that we can come up with some a bit of creativity and innovation in terms of different ways we can try and solve this versus all of us trying to necessarily do the same thing. So maybe something coming back from HHSC to say, hey, let's kind of fund a pilot or find a ways to fund a pilot and get some plans to get involved. Maybe that's a suggestion the state can kind of take back as a place to start, to look at the value proposition of how we kind of fund or support SDOH initiatives, going forward.
Yeah. Thanks, Dr. Sorrell, for speaking up. I really appreciate that. I think the other thing I heard Diana and others speak at, it kind of sounded like, and if you looked at the chat and the different various questions, it sounded like there was some additional maybe interest in looking into digging in a little bit more into the Z codes. Seems like that several different plans, I think, have asked questions or brought that up today.
That's great. We'll definitely save the chat just to have a memorial of all the different questions that were asked. And keep in mind that this is a learning collaborative. We're here to serve as resources to you. We're also here to really cultivate good learning opportunities for you and discussion opportunities. Something that we've discussed as a group is potentially a part 2 of this discussion, if it would be helpful. We can also do a smaller stakeholder group to discuss some of the nitty gritty in detail outside of a large discussion with 100 people on the line. So don't be shy, don't be a stranger, and definitely we'll rely on Lori and Kay to bring back some takeaways as well.
Great. Thank you guys so much. We really appreciate it.
Thank you.
Thanks for having us.
Yeah, thank you to all of our presenters, Milliman, HHSC, Xiaoqi, and also we'll be sending out a survey where that'll be a good opportunity for you to put in your interest in a particular subject matter, and also agree that we need a phase 2 of this discussion or not. So thank you for joining us today, and stay safe.